Hi, everyone. I'm Dellann Elliott Mydland, President and CEO of the End Brain Cancer Initiative. And our mission is to help patients with disease in the brain, with cancer in the brain and the central nervous system to receive the best care possible and to educate them about the necessities of considering a clinical trial and advanced diagnostics as part of their treatment options. And today I have the pleasure of getting to spend some time with Dr. Christian Grommes. He is a specialist in the disease known as PCNSL, and I want to tell you a little bit about him before he gets to talk, okay? He is a neuro-oncologist, an early drug development specialist at MSK in New York. I looked at his resume and you incredible work you are doing, incredible accomplishments, and your research and your publications from that research are vast. And I just want to say thank you to you because
Thanks.
truly, you really have dedicated your life to research and to this disease as well. So thank you. His areas of expertise are primary brain tumors, CNS lymphoma, central nervous system lymphoma, and brain metastases. We are so delighted to have you today, Dr. Grommes. We need more people, special people like you. Thank you. I also want to thank Curis Therapeutics for bringing us together, for investing in the disease of PCNSL and into this research, and for helping you and I and the End Brain Cancer Initiative with this educational video for patients and the PCNSL community and the distribution, which will be global, helping us with this project. So thank you, Curis Therapeutics. And now we are going to move into section 4, which is interesting. It's challenges and unmet needs. And so when we say unmet needs, from a patient advocate perspective, I'm thinking about what patients have said or expressed and their care partners about what is unmet, what their needs are that are unmet. But it's interesting to talk to you because I would imagine specialists such as yourself in this particular disease state have distinct unmet needs. Is that something you would like to address?
Oh, yeah, I want to address unmet needs because, we talk now for a long time that this is a treatable disease. We have remissions. We even potentially have cures. And yet, when we looked at a larger US database for primary CNS lymphomas and how survival, not just response, survival has changed. It changed in the 1970s from a median overall survival of 12 months to now a median overall survival of 24 months in the US. And that is not what I just talked about. And so there is obviously an unmet need. The unmet need is particular in those patients that are older than 70. And so these patients might not be able to tolerate a lot of methotrexate chemotherapy, or they run into difficulties with methotrexate chemotherapy, or they decide, I don't want to be admitted every 2 weeks in the hospital, so I don't want any treatment. And so that is, for me at least, the biggest unmet need. For the patient, I think the unmet need is to define what kind of treatment do I choose. And we haven't even talked about radiation at all, but it is possible to give radiation in these patients. And what treatment do I want that, if I am literally cured, gives me the best cognitive outcome in the long term? And so that is an unmet need. But again, the problem is, how can we make upfront treatment better so we don't run into recurrences? And that is another third unmet need, is that we don't have a biomarker that can define something we call minimal residual disease, that we don't see on the MRI scan or spinal fluid collections, that defines a patient at risk for an early recurrence. And we don't have that.
We don't have that yet, maybe.
That's right.
Yeah. Okay. Because, boy, that would be beautiful.
Yep. Also, you could spin it further. If you have a biomarker that predicts that you're not at high risk of a recurrence in the first place, why doing all these aggressive treatments? So you can peel off chemotherapy even.
Okay. That's interesting. That's a very interesting philosophy, but also just a very interesting practice. Because I noted that earlier when you said, I interpreted it as you like to start aggressive. You like to give the patient, if possible, everything in your toolbox.
Yeah.
Right? To get rid of this disease. And then if you need to, you use the word peel back. Is that a your word, or is that like a doctor term?
No, I think that's my word. Yes. Yeah.
Well, I like it. And it
Yeah.
makes sense. You just peel back, different treatments if the patient, is not responding well. That's great.
Yeah.
Wow. Wow.
Yeah.
Okay,
But
so
it would be nice to have something that I could categorize patients up front and say, you are at really high risk to have a tumor growth within the next 6 months. And we have a patient, you have a low risk of having a tumor growth within the next 5 years. Then you can approach this and say, well, why don't we treat these patients potentially differently? I think that's really missing at the moment.
it is missing. I mean, I know, there's a lot of research going on in this area, like even liquid biopsies, right? Like, and so I suspect from a healthcare provider and researcher perspective, that would be amazing information to have up front. But I also think from a patient perspective, care partner perspective, family perspective, having that information up front, I think it would be beneficial for that patient to have that information, because I do think I think more information the better to
Yeah.
make informed decisions. I mean, I feel like if I were this is me, so I'm just sharing. If I, having been through a illness with my late husband, if and now there are tests to help determine this, but if we had known some of what can be detected now, as far as pretty much how fast it's going to come back or not, those would have been very helpful. That would have been helpful information to have up front for so many reasons, right? We might have chosen to do something earlier than later. We certainly might have chosen to be more aggressive in treatment. We might have considered even like a clinical trial sooner than later. That kind of information is just, or we might have taken a trip or something
Yeah.
also. I mean, who knows? But the more information, the better, to help not only the physician and the researcher and the healthcare provider and the principal investigator of the clinical trial, but it means so much to that patient and their family. I think we should really move in that direction.
Yeah. Well, if we
You know,
can, see, that's the thing. But that's also going back to the second opinion. You should, there's a fine balance. If you get one second opinion or 2 second opinions, but sometimes what I also unfortunately see, not so much in lymphomas, but more in glioblastomas and gliomas, is that there is a newly diagnosed patient. It's a highly aggressive tumor, and there's one after another of second opinions, and time ticks and ticks and ticks, and no one does a treatment. And so
gotcha.
that is something that, I encourage second opinions, but there has to be a point where you say, okay, now it's enough. Let's move on to treat.
Right.
Yeah, because
Right.
I think I see the second opinion more like an opportunity for the patient to learn more about the disease and to hear, are the recommendations about the same? Are they different?
Mhm.
There are some people, I have strong opinions sometimes too, but I think in general, 80% of the information everyone gets is about the same in all the encounters. And then the last 20% is all about how I treat and what I do and my trial portfolio versus another trial portfolio. And that's
Yes, exactly. It's about more about what the healthcare provider at wherever they're at, has available to be able to treat the patient, right? Yeah, I mean, but see, all of that is really good information to have.
correct.
This is just me speaking. You're right. You do not want to get in a habit pattern or whatever of getting so many different treatment options and prolonging treatment for a long time, because you certainly don't. I mean, treatment is your friend.
Yeah.
You need treatment, but you do need to make the best decision possible for your particular disease, particular makeup of your tumor, that kind of thing. I almost feel like sometimes 3, and then you're going to know. You're going to know.
Yeah.
You're going to know where what you should be doing. And so anyway,
there's maybe also, if I may, another thought about that is
please.
there's life to live, correct? And so I'm the first person to love enroll patients into a clinical trial, but does it make sense? Does it make sense to travel 6 hours every day for a clinical trial? Unless this is like a game changer,
Right.
maybe not. But that's a little bit also where the conversation with the patient comes into place. It's like, okay, this is your situation. This is what we can offer. How can we make this fit? And having, for example, and that's also, I think, something that's unmet need in our field, is to have patients do their assessments more at home, like the MRI scans and the lab draws and all that, instead of coming to the centers that offer the trial. But these are more philosophical approaches. But I think that there has to be a good conversation about what can be done and what should be done.
Right. And you're right. The patient does need to make a decision.
Yeah.
And it is about quality of life. It has to be an informed decision, though. That's the thing, is you don't want patients making a decision without the information that is rightfully theirs to have.
Yeah.
And so, yes. And so I really liked what you just said. Wouldn't it be wonderful if patients could have basically their lab work done at home, some other things? I don't want to get off the topic, but what do you think about decentralized clinical trials?
Well, we're playing around with this because, obviously the pandemic has changed a lot. Telemedicine finally has arrived. How we take care of patients. Patients also don't want to leave home. During the pandemic, they didn't have to do it. So why now? But that's the idea, to kind of think about new ways of delivering care. And so sometimes there has to be a physical interaction. But we try to design our trials in a way that we build that in. Actually, for example, again, this is not promising as lymphoma, but in glioblastomas, having radiation locally makes a big difference, because that's a daily thing. As long as there are basic things covered about the dosing and the schedule and things like that.
Right.
But I think that is where this is having. Well, I hope that is the direction that we're all heading. Yeah.
I hope so too. I do. I have a little bit of a question. It's sort of related. MSK stands for?
Memorial Sloan Kettering Cancer Center.
Yes.
Yes.
In New York City.
Oh, actually, we have satellites in New Jersey and in New York State.
So you have the Rockefeller Outpatient Pavilion.
Yep.
In New York.
Manhattan, yep.
Manhattan, okay. Where at in New Jersey?
So we have in the south of New Jersey, which is Monmouth, which is at where the beaches are.
Yeah.
Then Baskin Ridge, which is kind of like more not central New Jersey, but it's more towards the center. And then Bergen County, which is in the north of New Jersey. Then we have Westchester, which is not upstate New York, but for New Yorkers or Manhattaners, this is upstate New York. And we have Long Island location.
Oh, you have
Yeah.
Long Island. I didn't know that. I didn't know that. So then the natural question then is awesome. And the question then is, at these satellite offices, if we're talking about PCNSL, what is available to them at the satellite
Yeah.
places that you mentioned?
Well, not me personally, but I unfortunately only see patients at the moment in the city at our Coke facility and then 53rd Street Rockefeller Outpatient Pavilion. But we have neuro-oncologists and neuro-oncologists that treat and see primary CNS lymphoma in all our satellite facilities. And we design our clinical trials in a way that patients can receive the trial treatment in these locations. Some of them we
Fantastic.
can't do detailed pharmacodynamic and pharmacokinetic testing, but we're working on these things. But yeah, no, these recurrent refractory trials are all open. The first line, not because methotrexate is only given in the hospital in the main city, but they can receive portions of their treatment in the satellites. Patients like that because parking is easier and
Yes,
it's much better.
yes,
Yeah.
yes. Patients really like that.
Yeah.
Yeah. And so do the neuro-oncologists who are at those satellite sites, do they all get together for tumor boards to discuss a patient case kind of on a weekly basis, that kind of thing? Okay.
Yeah.
Maybe talk about that just a little bit if you would.
Yeah, so actually a lot of those neuro-oncologists having sites in Manhattan and the satellites. So because of the, I see mainly CNS lymphomas. And so there's a lot of lymphoma doctors in the city. So, that's why there's a lot of referrals and that's why the space needed to be in the city. But it can be that within the next 1 or 2 or 3 years, I also have a satellite office. It's just very fluent and it's not like I don't know how it is in other institutions, but when there is a label that says MSK, it is MSK doctors and not, the labeling out. So it's the same doctors and the same standards, and these doctors rotate. Or have seeing patients in the city or in the satellites. Same trainings, they all come together. It's the same department. They do research even, themselves with their own protocols, and so I then see their patients in the city when they're in the city. So it's kind of like my extended arms. My patients go to these facilities, get their treatment. I can even see them when they're in the location as a telemedicine visit because, I just touch base with them that way. It's very nimble because, again, it's to make sure that patients get access and get their treatment done and don't have to travel to the city.
That is fantastic. I mean, that works well for everybody. It's less, what's the right word? Rigid?
Yeah.
Yeah. So that's great. That's really
Oh, yeah.
great. Do
Yeah.
people know that, or is that just something that they ask about or they find out about, I guess, when they're diagnosed, or, it, is that, you know what I mean?
Yeah.
Does MS
Yeah.
do a great job getting that information out there?
I think then they don't know it immediately, but they learn very quickly because they
Okay.
ask. I see
Okay.
someone here or there, and it's people also travel. They have their weekend home in Long Island and they live in the city.
That's
So
true.
yeah,
That's true, actually. That is great because you know what? That's increasing patient access,
yeah,
which is the core, that increasing patient access and increasing patient treatment options is at the very core of what you're doing, and increasing patient quality of life and survivorship. So amazing, amazing work. So we are in the challenges and unmet needs session. You've talked a lot about a couple of things I wanted to talk about, and you definitely talked about access to experienced centers earlier on in this interview. Is there anything else you want to add to that particular topic?
well, access. Well, again, I think it all boils to try to get a second opinion. And yeah, if you have a rare disease, you want to go to a place with rare diseases. Same thing with if you have a complicated surgery, you want to go to the surgeon that does it every day instead of the surgeon that does it once a year.
Agree.
I think that is the idea. Or if it's not possible physically to do that, then at least have someone who is experienced in that field guide your local team or work with your local team. And I think that helps, patient outcomes, patient access, and don't be afraid of asking questions. That is another thing. Very important.
Very key important. Don't be afraid of your healthcare team.
Yeah.
It's okay to ask questions. It's okay to be concerned. It's okay. You're not going to offend them. They want you to ask questions. They want you to be comfortable with them. They want to hear from you. It is a partnership. And the more communication, the better. And the more communication leads to better outcomes. So this is just my suggestion out there to all of those patients and families and care partners who will see this. Do ask the questions. Never be afraid to ask a question. Every single question is very, very important to you, and therefore you should ask it.
Correct. And the burden should not be on the patient to decide if it's an important question or not.
Every question is important. Every question is important. So, what do you see, Dr. Grommes, as gaps in care and research for the PCNSL community?
Well, again, I think the problem is in cities, in larger cities, you have centers of excellence, and in rural areas, this is more difficult to get to. That's one. Access to clinical trials is obviously limited. If you don't go to a specialized center, even a specialized center might not have a trial in PCNSL. And so it's challenging because it's a neurologic disease with a cancer that not a lot of neuro-oncologists treat. And so finding the expertise and the trials is, I think, the most problematic thing. Also, we're facing a more and more elderly patient population, so we will see more of promising stuff.
Yeah, so maybe we could talk about that just a little more. You have talked about we are seeing an aging population with more, of course, we're seeing a larger aging population, and so we're seeing more people being diagnosed with PCNSL who are older. So that brings up a topic, which is the need for better and less toxic treatment options, less toxic therapies. So that is important for patients to understand, is that there is work going on in that area. Just think if you could take a pill instead of having to be admitted for 3 to 5 days wherever you're at for treatment for PCNSL. Just think about that. There are advancements coming in this particular disease that should be easier for patients, including our older patient population, to utilize.
Yep, there are trials ongoing for that. That's right. But you also have to keep in mind that whenever you change a treatment that has the potential for a cure, then you have to be very careful, because you don't want to miss that chance that the patient has. So, but yeah, that's the idea, to reduce the toxicity of the treatment, the problems that come with being admitted and all that, to a more easier treatment. But that treatment needs to be safe, and that's what we're working on.
That is definitely. In working with PCNSL patients and their care partners, they have shared with the End Brain Cancer Initiative that one of the things that they would like to see when diagnosed is much more information given to them on their diagnosis and also on the potential, the treatment options and the potential treatment options, clinical trials, things like that. How do you, as a physician, researcher, how do you move that kind of what I guess is a real unmet need? How do you move that forward?
Well, we do a lot of patient education already. So it's not only me that talks about it, it's the nurse practitioners that are in the inpatient setting. We have a pharmacist in the in and outpatient setting that is there to educate patients about their treatments and therapies and side effects. So there's a constant, ongoing, repeated education about the regimen, the chemotherapies, the side effects, what to look out for. And again, these patients are in the hospital every 2 weeks, so this is an ongoing education of the family and the patients, and it gets very routine after a while for them because they got that education. But that's what it's all about: it's the communication, education, the constant reminder. What are the side effects? What we're looking for, and so yeah, I think that is the way to overcome that lack of knowledge.
Do these patients and or their care partners receive a survey related to what they might perceive as an unmet need or perceive as an amazing need that was filled?
That's a good question. I'm not sure they get a survey for a particular that. They get a survey for, the hospital stay and the care, and
Yes.
but not in particular like, ooh, what are the things that you want to have more information about?
Okay.
Well, it's a good idea, actually.
That's a great idea.
Yeah.
And I know that we have some of that information. We did a survey. And so the one of my we're getting to where we're going to wrap this up. I'm curious because I do not know the answer to this question. Does MSK have a support group for the PCNSL community?
And not in particular for the PCNSL community, but for brain tumor.
But they have a brain tumor.
Yeah.
Okay. So the PCNSL community would be included in that. Okay. Do you know, is that like a monthly thing or?
Yeah, I think it's a monthly theme. Yes.
Yeah.
Social worker does run that, actually.
When you have a moment, would you mind emailing me that information or even just an introduction to that social worker? I would really like to talk to her about that, and I certainly would want to make sure patients knew about that and their care partners.
Mhm.
That sounds good. Okay.
Yep.
So, hey, we're wrapping things up. Is there any last thoughts or comments you would like to share with our audience?
Well, I'm blessed working with promising lymphoma patients because I do, we generally have a more upbeat vibe in our clinic because people get better, they do better, they have follow-ups without any, changes on the MRI scan, patients are in remission. So it's just a different patient population. And so, we always say when you have a brain tumor lesion, we always hope that it's a promising lymphoma versus a glioma because we have more options and we can do more. But yeah, it's still a rare disease, still a little bit of an unmet need and to improve on. But yeah, I think it's an exciting time to be in promising lymphoma research too, because there's a slew of new treatments and treatment options that will come down the road that we can apply to our patients.
That will be very exciting. That's that completely exciting. And I know that we'll probably get to talk about some of that more in depth. I know there's probably going to be some other opportunities where we'll get to do something similar to this, where we can actually talk really specifically about that and those potential treatment options. And that's, that's education. And that's so exciting as well. So that's wonderful. What was that? I'm so sorry.
I would be happy to do that. Yes.
Oh, good. Oh, I have to talk to you then. I just wanted to actually add another comment that a patient wrote, if I may.
Oh, yeah.
Dr. Grommes and his staff is the very best in the business. Always excellent and so experienced. I mean, that's so fantastic. I did appreciate what you said, that your clinic is kind of upbeat and kind of, I'm not sure I can say that about a lot of clinics that I've been into. So,
But yeah, but it's even if you have a high-grade glioma, this is an anxiety introducing situation. So, trying to ease that situation, that experience for our patients helps. Again, I like to offer options and choices, no matter where we are in the journey of a patient. And I think that also helps to ease a little bit the anxiety to say, well, at least, we have something to talk about. I might not be able to offer a lot of treatment options, but we still have, support options for symptoms and things like that. And
absolutely.
there is, I think seeing this, if I feel nihilistic, then my patients feel that immediately, and that's not what I should do.
Well, I appreciate your and your team's philosophy because you're absolutely correct. This uh, disease is hard,
Yeah,
and anytime you can make a patient or their family or their care partner smile while they're also in for a consult or treatment, wow,
yeah,
that's actually part of the treatment.
that
You
is
know,
correct. Yeah,
it really, really is. It's very special that you do that. And I promise the next time I'm in New York to come by and say hi.
that would be nice.
Um,
Yeah,
yeah, I've been to MSK, but it's been a few years. But it's, now I have a reason to go back. So this is really great. Dr. Grommes, thank you so very, very much for spending time with us today. And your knowledge is exceptional. And you have just helped so many people understand this disease, like the general public, but you've also helped that entire PCNSL community understand more about this disease as well as the treatment options. And so I thank you very, very much. We just don't get enough opportunity to create these wonderful opportunities of education. And so I value your expertise and your time so very much. So thank you. And we will add in a graphic that has your contact information. We'll approve it with you first. And then we'll add in a graphic that also has contact information for the In Brain Cancer Initiative's patient navigator as well, because we can help get you to those whatever centers of excellence, right, in the PCNSL area and get you those second opinions that Dr. Grommes did speak about. So here working for everyone as a team for this patient population, and it is an honor to serve the PCNSL patient population. So thank you for allowing us to also do that in partnership.
well,
Thank,
thanks for having me. Thank you so much.
thank you so much. Have a great rest of your day.